And back to my comments before about patterns. You know, I like to look at patterns. I like to see what a particular drug will do to the patterns, talk about it with the patient, and say, okay, here I'm giving you this drug. This is what we're looking for. Go home and monitor, and let's see if you see that. It engages the patient. Now, SGLT2s can work in many people, both on the postprandial and in the preprandial, which I think would be helpful here. And I would have the patient monitor and see if we can gauge how much of an effect is seen, and that will really get them involved in their treatment decisions. Do you take that approach?
I agree, and that actually buys you something that you didn't have at that first visit, which is time. Because you're competing with his back pain at that first visit, you bring him back 2 weeks later with that data, and now you can actually explain to him, here's how this medicine works in your body, and here's what I expect to see. So sometimes we need to buy that little bit of extra time in managing our patients.
Yeah, and you know, one of the things we always talk about being aggressive, and you spoke about advancing therapy rapidly, but sometimes the balance between rapidity and giving it a little bit of time, get some more data, think about it. Don't bring them back 5 months from now, but bring them back, 2, 3, 4 weeks from now is a good strategy to get them more engaged.
Totally agree.
All right. So I think that we've tried to give you a sense as to how an SGLT2 inhibitor might fit into a treatment for someone like Jerome. In many of these patients, there are a number of options. Incretin-based therapies, GLP-1 agonists, DPP-4 antagonists, and there are other medications for the other of those octet of defects that can be used. We focus mostly on SGLT2 inhibitors today, but I think one of the things that has come across in our discussion is that it's not a cut and dry decision. There are a lot of factors that we think about: weight, age, confounding conditions, etc., that come into the discussion and have to be considered when developing the titration and the medication advancement therapy program for a given patient. I think we're at the point now, Mark, where we can handle a couple of questions that have been coming in from our listeners. And a couple of interesting questions here. We alluded to this to some degree. One person wanted to know, since pioglitazone causes edema, would this class of drugs attenuate that effect?
So although it's not been specifically studied, the weight loss with SGLT2 added on to pioglitazone is no different than the weight loss when you add it on to any other therapy. So that would probably indicate no. Also, the weight gain or the fluid retention associated with pioglitazone is through a different renal mechanism than the sodium retention with SGLT2. So it apparently does not counterbalance.
Nice theory. Are SGLT2 inhibitors more effective in combination with certain therapies as opposed to others? I don't know that I've seen anything that suggests that.
No, and I think the data that we presented earlier didn't suggest any difference. The one aspect that may be a little different and has not yet been studied is there seems to be an increase in hunger that occurs after about 6 to 12 months on these therapies, whether or not there's an effect on weight that's different when an SGLT2 and a GLP-1 are put together over time. But otherwise, I think they're all the same. The efficacy is the same.
And I think ultimately, as we look at what's done in the real world, there are some people, for reasons we can't really fathom, will respond well to certain drugs and not to others. We're clinicians. We start something, we titrate it, we see how they do, and if it's not efficacious, we move on to either switching it or adding something else to get them to goal.
I think that's one of the problems in diabetes is when it doesn't work, we don't get rid of it. Blood pressure, if it's not working, you get rid of it. In diabetes, if the metformin doesn't lower the A1C, we hang on to it. And I'm not quite sure what we're doing when we do that.
Well, in many respects, it may get lost in the shuffle, and that's why, again, I come back to the patterns. If you've started the metformin and you see that it's lowered the fasting sugar a little bit, but it may not have had enough of an effect on the A1C, well, then you can have the discussion, if I'm moving on to something else, do I still want to anticipate that metformin lowering? But if you haven't looked at that, thought about it, engaged it, then when you want to make your next decision, you don't really know whether the metformin did anything. Same with a DPP-4 inhibitor. It's a good drug, not tremendously effective, but it can be effective in postprandial. And if you look at the postprandial when you start it, if you have to move on to something else, you'll at least know whether it's having an effect there.
Exactly.
All right. There's a lot of concern out there about using these medications in people with urinary tract issues, and we probably should cover that. Can we use these drugs in men with BPH? And there's also questions about how do we look at histories of urinary tract infections, both in men and women, but predominantly in women, and when would it be a contraindication for the use of the class?
So intuitively, you'd think that BPH would be an issue, but the discontinuation rate among men was very low. And when you think about it, the kind of patients you're going to be using this drug in, they tend not to be the older patient population because of GFR issues, so that may be why. But the discontinuation rate was low for that. There's no specific guidance of how many urinary tract infections in women or of a history of pyelonephritis contraindicates these medications. I personally, if there's frequent UTIs or a history of pyelo, I won't use them. What's your take on that?
Yeah, I would agree. I think if somebody has had particularly women will typically have a long history of recurrent urinary tract infections, I don't use it. Just because they've had one, or oftentimes you get the history they had them during pregnancy years ago or something like that. I don't view that as a problem. The other challenge I see is that a lot of women will have asymptomatic bacteriuria. And people will look at that, and often primary care doctors are confounded with the question, do I treat, do I not treat? And how does that play into the SGLT2s in your opinion?
Well, I think the biggest issue with treat, not treat is if you look at it, a patient who's got poorly controlled diabetes has far more glucosuria than a patient with an SGLT2 inhibitor. And so many physicians wouldn't institute insulin with an A1C of 8.8 or 9. But that patient's at a greater risk for a urinary tract infection than the patient you'd put on SGLT2. So I think when you make these kind of vague decisions, you look for FDA guidance, but then it's really kind of up to the individual practitioner.
Yeah. And the key thing is to talk to the patient, tell them what to look for, and if they're having problems and have a conversation, you can always stop it. Same with men that are uncircumcised with balanitis. Same sort of issue.
Great.
I've, in my experience, I've had a little bit of an issue occasionally with patients. Most of the time, it's not an issue.
And when it is, you got other choices. You got other tools.
You bet. Question here, do normotensive patients have hypotension? Do you run into that? I assume the questioner means normotensive without treatments.
So you wouldn't expect that because the average drop is 5, and in a normal individual, they should have appropriate counter-regulatory response so they don't get orthostatic.
All right. Is there a specific A1C where it might not be effective? We all know that a lot of the studies that have been done look at, on these drugs, look at various A1C levels and how much of a change. Do you think of a specific A1C that's more or less effective for these drugs?
I think they're intuitively more effective earlier. If you have a patient who's 9.5, they're already beyond their tubular threshold and they're spilling huge amounts of glucose. I don't know that you're going to accomplish a huge amount in those patients. Anyone who's 8.5 or below, you could consider the addition of one drug, but let's face it, if you're above 8, anything you add is not going to get you to goal. It's not likely. And so you really need to think of mechanism. What am I missing? The pattern, as you talked about it.
Yeah.
What am I missing in this patient's regimen that he is above 8? Am I not addressing his beta cells? Am I so insulin resistant, insulin providing strategies won't work? So it's patterns and mechanisms that I think help define what that A1C is rather than a specific number.
And finally, we just have a minute or two left, but this is often asked. Would these be usable in people with type 1 diabetes?
So it's been studied.
It's not indicated.
Not indicated. It has been studied. It is intuitively attractive because it's non-insulin, but there have been reports of normal glycemic ketoacidosis in these patients because of the compensatory increase in glucagon. Signal unclear, but so until that issue is resolved, don't try this at home.
I would agree. There's some people with type 2 that sort of begin to lose beta cell function, and there's type 1.5 or something in between, and they still may get some efficacy from it, but you have to use it with caution.
Agree.